Good evening, everybody. Thank you for attending my presentation today. My name is Amro Taha. I'm one of the BGY5 cardiology fellows at West Virginia University. Today, I will be presenting on clinical outcomes on mechanical thrombectomy that being performed on patients with PE and cord pulmonary. So as Dr. Khalik and Dr. Patel have already presented multiple evidence and emerging data now are ongoing on support of the interventional approach in treating people with intermediate to high-risk PEs. So we all know that like the bigger the PE, most of the times that associated with a higher right heart strain and worse outcomes and higher risk of obstructive PE that has been proven through multiple studies. In our institution now, we are part of the Peerless 2 trial. So we mainly focus on patients with submassive PE. They characterize this by the presence of a systolic blood pressure that's a little soft, but not super soft, 90 to 100, lactic acid of 2 or higher, tachypnea with high respiratory rate, and tachycardia. So the patient is in there and in danger of shock, but they're not there yet. At the same time, we do run the same procedure on patients with very high-risk features, like, for example, people with PE and right heart strain that the RV couldn't tolerate it anymore, and they're now in frank RV shock. What we have seen with my colleagues, actually, and this is where the study came from, is that even with those people with very difficult situation and RV failure, they do benefit, actually, tremendously from these procedures. And we can see the next day, immediately, they will be intubated on 3 pressors, and the next day, they are on room air sitting. They are on oral anticoagulations. So, and hence, this is where the idea came in from. So we did study, actually, in the time frame from 2018 all the way up to 2024. We went through we extracted this data from the Trinetics database, which is kind of similar to the NIS and RD database, but with more granular data and with temporal trends. So that gives us an advantage of correlating those outcomes with this particular diagnosis during index admissions. So 2018 to 24, we used TBT codes and ICD codes for PE mechanical thrombectomies and RV failure, respectively. So we performed propensity score matching, and we did run a risk assessment with hazard ratios on those patients. We did follow them over a 365 days period, just to kind of get a long and short-term outcomes. I know PE most of the time is short-term outcomes, and we should have studied. For example, somebody might ask why you didn't do it over 3 weeks or a month period. But at the same time, given the presence of an RV failure, and those people, sometimes if the RV-PA coupling gets into the other side, they might develop actually chronic RV failure in a small subset of these patients' populations. So we did actually adjust for multiple variables. We haven't included everybody, especially the hemodynamics part, tachycardia, hypotension, oxygen requirements, and all of that, because we do assume most of the times if there is an acute PE that's causing cord pulmonary, these patients are not going to be stable. Even if they're unstable, probably their shock index is a little on the concerning side. So as you guys can see, we did adjust for all the demographic factors, all the comorbidities that might increase the risk of bleeding and that might preclude patients from undergoing TBA or systemic thrombolysis there, including thrombocytopenia, history of stroke, the presence of tumor, anticoagulation use, and various data. Here I'm presenting the post-matching data, so you guys can see that there is actually very few variables here that hasn't been matched between the 2 groups. So we ended up with almost 58,000 patients who had the diagnosis of PE along with RV failure. Almost 6.5% underwent mechanical thrombectomy, and the rest of the 93.5%, they went for non-mechanical thrombectomy approach, meaning those people got treated conservatively with anticoagulation, with TBA, catheter-directed thrombolysis, all of that. But for the sake of getting like comparable groups, we actually did the subgroup studies, and we included only patients who got some sort of systemic thrombolysis, or actually we included catheter-based thrombolysis as well in these groups. Just, again, clinical-wise, if you're having a patient with massive PE and RV failure, you're probably not going to treat them with anticoagulation only. So we ended up with 1,600 patients in each group. And we did follow them over a year, as I said. And we found that people who underwent mechanical thrombectomy actually had significantly lower hospital mortality and the need of invasive ventilation, mechanical ventilation, with similar risk of bleeding and stroke. And we hypothesized actually why that is because of the nature of the RV. It's a delicate wall compared to the LV. It cannot tolerate a lot of pressures and hence the obstructive shock and RV failure. So with a rapid unloading of that RV, which doesn't happen with systemic embolization most of the times, there is actually a quick reduction of that pressure in the pulmonary circulation. So that's the difference between actually chronic pulmonary hypertension with CTIF versus acute PE. Once you take that clot out or the obstruction out, most of the times the RV actually goes back to semi-normal, if not normal. So statistically significant result, and we concluded that in this real-world analysis, high-risk patients with acute PE and concomitant diagnosis of RV failure might benefit actually of mechanical thrombectomy. And this might open the door for further investigations of the high-risk category patients. Most of the trials now are running on intermediate high-risk patients. So we hypothesize that even if you are there, even your RV has failed, there is a good chance that you might come back and the risk of mechanical ventilation and mortality is way lower statistically and clinically. So here at the top, we can go actually, there is just 1 or 2 points about the actual numbers and values. So 0.6% is the hazard ratio if you go for mechanical thrombectomy versus conservative treatment, including TPA, which has been the standard way of treating those sick patients or the patients are in shock. And you can say also the major bleeding, the confidence interval is a little wide because I'm assuming this is because of the smaller sample size along with intracranial hemorrhage. But as you can say, it is statistically significant. The statistically significant difference between the mortality and the risk of mechanical ventilation between both groups. And actually, we included palliative evaluation and hospice encounter in these patients just as a surrogate of the discharge planning. But there was no difference in that. So we conclude that mechanical ventilation works in high-risk patients. Thank you.